Right, I'm Joanne. I'm a clinician working in the field of facial pain, and particularly trigeminal neuralgia, in which I'm an expert and have done several trials. So it's a rare disease, at least classified as rare in the US. The Europeans haven't acknowledged it as a rare disease, but it's a unilateral facial pain that can be suicidal, and we have examples of suicides that have been committed both here and abroad as a result of this disease. So it's a problem, and it's also got a difficult natural history in that there are periods of pain remission, and so the quality of life does vary throughout the process of the disease. But we think it's probably a progressive disease. We've done, as yesterday was said, we've done all the systematic reviews, both of drug and surgical management in clinical evidence. We've even had a podcast and an article in BMJ about it. The problem is there are two treatments. There's drug therapy, which is purely symptomatic, but gives big side effects. There are surgical managements, which again are not curative, but give much longer pain relief periods when they don't have to take their drugs. There are 5 surgical procedures, which again have different risks and harms associated with them. And the problem is, what do we do and what are the challenges? Well, we've, for the first time ever, had a new drug developed. We've just got the phase 2 study, which we hope will be accepted in Lancet Neurology, and we're hoping to do phase 3 on an enhancement enriched design so that all patients will contribute to that. Timing of surgery, when we've looked at guidelines, we haven't got an idea of when should patients be offered surgery. At the moment, we tend to do it when the quality of life diminishes. The neurosurgeons are telling us if you do surgery earlier, then you have better outcomes, but there's no good evidence for it. And there are varying surgical options, and there's the natural history of the disease. So what I've been doing over time is I set up a cohort study knowing nothing about Twixes in 2007. I've now got a group of over 200 patients, which I'm just trying to publish the baseline data. And now I want to convert it potentially into a Twix, which is what Claire and myself have been thinking about and putting to the surgical community. Firstly, I've got a drug trial that I will be doing. Can I it'll be an enhancement enriched drug trial, international trial, both Europe and the US. And from this cohort, I will be selecting patients for that study, but could I use the others who are potentially not eligible for the study for one reason or another? Could I use them as my sort of control group as well? Because probably some of the outcome measures we're using here will be used in that drug trial. The other thing is, could we put patients through surgery earlier? And one of the options that we're talking about is, could we ask patients to go for early surgery? When I've gone to the patients to ask them, because we have a patient support group, they're saying, no, I don't think we want surgery early. You've got to show us the evidence that it's worth having surgery earlier. So if we were to try and randomize patients to earlier surgery, would we have a big dropout area, as we heard yesterday, that then it affects the quality of the data? And some patients don't want to have surgery, and there are 5 surgical options which have different harm. So I'm not sure, is this potentially a good design to do, and can I convert my observational cohort into a Twix?
What is the first question you would like us to answer?
Can I convert this into a Twix?
Is there anyone who's prepared to come?
Because at the moment, all I've consented my patients for is an observational study, filling out questionnaires at 3, 6 months and yearly timing. Unusual care.
The immediate thought is, yes, you can, but you need to go back to ethics and revise your concept form to reflect this. All right.
It's an option to go back to the patient and ask them for consent.
Okay.
I potentially could. I mean, I've still got the patients are there. They're very good responders. I've just about got the drug company have agreed to help me do the survey, the annual survey, because they want to prove there's an unmet need for a new drug. So they're interested in funding a study.
So the other thing you'd have to do in your to convert it into a TWIC is to make sure that your outcome measures for the cohort were at least comparable or useful for the trial that you want to run. So if you're going back to ethics to redo the consent, then you sort of want to make sure that they tally as well for your trial outcomes.
And somebody was talking about the package of questionnaires, which sounds a good option, which I think is the one I would go for to ethics.
I think on converting it into TWICs, you have two ways of doing it, it seems to me. You could first randomly select a group of people who are eligible for this drug and approach them as if it was a full randomized trial, and go to the other patients who are not selected randomly and ask them for consent to use their data. Or you could go back to everybody and do a normal TWICs consent and then approach. So I think there are two orders, and I'm not sure which one works better.
Yeah, I mean, my comments, you worried about the surgery. What's the downside?
Yeah, the problem of surgery.
Yeah. So what we're all talking about is, in TWICs, is randomization before. It's that you're not told to what you're going to be randomized before you consent to it. That's a key part of TWICs, not some other designs. And you just said that that's going to be a problem because a lot of patients just aren't going to want surgery at all.
That's right, whereas others might decide, yes, it depends on their quality of life at the time I approach them. Because sometimes they feel suicidal, they come into the joint neurosurgical clinic and they say, oh, surgery tomorrow. And other times they come in and they say, yeah, I want it tomorrow. And then 2 days later, they've gone into remission and they don't want it. So I've got that change of the natural history.
So you've obviously got yeah, so I mean, you've obviously got a major disadvantage. You got to stop thinking of like, well, TWICs is just one thing, right? Now, either we're a TWIC or we're not. Should I convert this into a TWIC and say, well, there's various advantages and disadvantages, and there's various methodological approaches here that are going to be useful or not. And what strikes me is the methodological approach that you can take from TWICs that's going to be useful is you're getting a lot of data anyway. I think the methodological approach that is not going to be useful is the randomization of patients without them knowing to what they're going to be randomized, because I think you're going to have problems on both arms doing that.
Yeah, because surgery, there are only 3 randomized controlled trials and they're all on technicalities rather than the trials themselves.
We'll take time, the last question.
Yeah, how long is the planned trial for the drug?
It's going to be probably 12 weeks because there's also an extension after completion of the randomized control trial. There's an option if you were a responder to have the drug for a year, because in phase 2 we couldn't recruit because they had to go back to their old drugs.
And you would have to do that blinded.
Yes, that section.
Okay, so you're only talking about TWICs for surgical intervention?
Possibly.
Because there's a lot of details here, because since you can't do TWICs with the blinded requirement, so I'm just trying to get a handle on precisely what the trial would look like, regardless of whether you could do it. But that was my question.
I would say that you need to sort of think long term over the next 20 years. What are the questions you want to know? Prioritise them now, and then the design will follow on that. So, cool.
Right. Thanks very much.